Hi folks, I want to wish everybody a happy Thanksgiving and a happy holiday season. And today I wanted to do also a little quick video for you for this Friday. I'm headed out to the Greater New York Dental Meeting, so I'm going to share this with you today on Thanksgiving. And I've decided I'm just going to pick a slide from my presentation. This one's from my advanced anesthesia block, and as you know, I do teach the advanced anesthesia course at the Harvard Dental School, and this one is a talk about intrapulpal anesthesia. Now, intrapulpal anesthesia is something that I've reserved only as insurance anesthesia, and what that means is that I never count on intrapulpal anesthesia as the primary method of anesthesia. I always test patients after giving the conventional block and infiltrations, and then move on to the interligamental shots and so on. And I have to get a negative test by doing a cold test on these patients and then go ahead and start the procedure. But when I do start the procedure, I always access the tooth in such way that I nick the pulp in such way that I have access to a pulp horn so that I can do an intrapulpal anesthesia for insurance, not as a primary method of anesthesia. These are patients that are already numb, so they don't feel the intrapulpal shot at all. But this shot will ensure that I have adequate anesthesia throughout the procedure and that the procedure can be guaranteed painless for the patient. So when conventional anesthesia fails as well, you have your typical possibilities of moving from your block and infiltration to then giving interligamental shots and then going to an interosseous shot when ligamental kind of fails. And the way you test these failing is with the cold test and repeating the whatever vitality test that you did at the beginning of your diagnosis. Then I would proceed to do the treatment. So I never do the intrapulpal anesthesia as a primary source of anesthesia because the requirements also for this are having an intact roof of the pulp chamber. The anesthesia is done through pulp horns, and then it's actually a pressure anesthesia. So your type of anesthetic matters less than having pressure, and that is really the key point. You do need to have an intact pulp for these cases. So I'm going to share with you this case. It's a mandibular second molar that requires root canal therapy. It has irreversible pulpitis. We've given the conventional block and the ligamental shot as well in these types of cases until I have a negative cold response on my vitality testing. Repeat before I get started. So I get the tooth started. In this case, I use a rubber dam, and I just want to also share with you this technique that I've learned, in which you can, after having your primary rubber dam isolation, if you need to have more isolation and a little bit tougher rubber dam push, and you don't want to have to go to a heavy gauge, you can add another rubber dam to your existing rubber dam. Anyway, so here we do access through the amalgam preparation that's on top of the tooth, and and then you rinse out any of the debris that's in there, and the access is done in such way so that as you saw here, I can just get that pinpoint exposure into the pulp horn, so that the key here is to make sure that you have a diameter of the opening is just the diameter of your needle, so that there is no backflow, so that all the anesthetic creates that pressure inside that can create immediate anesthesia. Once again, I want to emphasize that the patient should not be feeling the shot at this point because the tooth is already numb with the conventional shot. This is insurance anesthesia, and we go on and do the root canal procedure. It's hydraulic condensation in this somewhat of a C-shaped canal. As you can see, we finished the root canal and placed the BC liner on top and a little bit of Teflon, followed by CAVIT, and the patient's off to get the tooth restored. So keep that in mind, and please remember that you use only this technique for insurance, not as a primary method of anesthesia. You have your interligamental shots and your interosseous shots that you would be using as your primary methods of anesthesia, and then you do your cold test and you do get a negative. That's when you start to use the access preparation. But during the access preparation, that's what you would do. Also, if during the procedure your patient runs out of anesthesia, you never give an intrapulpal, because remember what I said, you do need to have an intact roof of the pulp chamber for the intrapulpal to work. So giving intrapulpal to a patient mid-procedure when the roof of the pulp chamber has already been removed during access preparation is only going to cause a lot of pain and suffering for the patient, and that's not really what you want. You want to make sure in these types of cases that you remove the rubber dam and give an ligamental or an intraosseous shot in these patients, and then maybe piggyback another block or a gout gauge shot with those as well. So I will in the future do more tutorials on anesthesia, as you know, that's an area that I'm really interested in, and I will do more tutorials on this. Okay, I'm heading out to the Greater New York Dental Meeting. Once again, happy Thanksgiving to all of you, and happy holidays, and I'll see you guys in the next video. Until then, for real dental, Nasseh, and let's save some teeth.